We are one of few cancer centers and multidisciplinary teams around the country that specialize specifically in treating patients with adrenal cancer.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Barbra Miller. Barbra is a surgical oncologist, and one of her specialties is treating patients with adrenal cancer. And she is the co-director of the James Multidisciplinary Adrenal Clinic, along with Dr. Lawrence Kirschner. Adrenal cancer is very rare, and the James Multidisciplinary Adrenal Clinic is a leader in treating this type of cancer. Welcome, Barbra.
Thanks, Steve. It's nice to be here.
You know, I thought it would be a good place to start at the beginning with some basic geographic anatomy. Where in the body are the adrenal glands and what do they do?
Sure. So the adrenal glands, many people are not aware that they even have them, but they are two paired organs that sit just above the kidneys on each side, and they're yellow in color. They sit behind the liver on the right side, and then they sit behind the stomach, the pancreas, and the spleen on the left side. And their job is to produce a number of different hormones, which hormones are helpers in the body. They help all the other organ systems work correctly, and they help communicate messages to make other substances and products. So the adrenal glands produce aldosterone, which regulates sodium and potassium in the bloodstream, as well as the amount of fluid in the body, and also affects blood pressure. The other hormone that it produces is cortisol. Cortisol is a helper that's a steroid. We hear about that during the pandemic as we give steroids to decrease inflammation in the lungs. Cortisol in excess can do very bad things to the body. It affects muscle mass and integrity. It changes the fat distribution in the body. It affects blood sugar. It affects blood pressure and a number of other things. The adrenal glands also produce testosterone or androgens and estrogens, which are sex hormones. And then in the center of the adrenal gland produces adrenaline, epinephrine, and norepinephrine, and that has to do with the fight or flight response. But there are other places elsewhere in the body that produce adrenaline as well.
So it sounds like it's pretty important. It's not like, I don't know, what's a tonsil.
Well, everything we have in our body is important except maybe the appendix. There are certain things that we can do without. But yeah, the adrenal glands are very important. And as I said, they're helpers. We have two of them. Things can work okay if you have at least one adrenal gland. But in patients who don't have any adrenal function, which is called adrenal insufficiency or Addison's disease, then we actually have to replace some of those hormones. Otherwise, you can have serious effects on your health, and some patients who don't have any cortisol at all can actually die from that. So it can be very dangerous, but we do have medications to replace the hormones that the adrenals produce.
So Addison's disease and some other diseases are things that can impact the adrenal glands, which leads us to something else that can impact it, cancer. Now, from what I understand, it's pretty rare. So how rare is it, and how does it affect the adrenal glands? Does it affect both of them or just one of them? Does it metastasize to nearby organs, and that creates even more problems?
So adrenal cancer is very rare. It affects about 1 to 2 per million in the population. So every year, there may be only several hundred people across the entire country who develop adrenal cancer. And it usually affects one adrenal gland, grows from within one adrenal gland, starting with one single cell, and then that cell multiplies just like other cancers. Occasionally, it can involve both adrenal glands. But most of the time, it's difficult to detect. And so these masses, these cancers can grow to a very large size before we actually detect them, because there's not a lot of nerves back in that area that lead to pain or other localized symptoms or fullness or something like that. Some adrenal cancers, maybe about 40% of them, will produce hormones in excess. And so sometimes we pick up the presence of a possible adrenal cancer just based on the hormone excess and the side effects of those hormones that I mentioned before. Adrenal cancer, because often it grows to a large size before we find it, it often is associated with metastatic disease, where that tumor has, those tumor cells have traveled to other areas in the body.
You mentioned side effects from the hormones. What would they be?
Right. So, like I said, pain is usually not how patients initially present. Often we will find these incidentally on CT scans that are done for other reasons, sometimes for abdominal pain elsewhere in the abdomen, where it's not the adrenal cancer that's producing the symptoms that patients are having. But if it's hormone excess that we're talking about, leading us to try to understand why somebody's having certain signs and symptoms, then those signs can include high blood pressure, worsening diabetes, weight gain, signs of what we call Cushing syndrome. Cushing syndrome is from cortisol excess, and cortisol is the most commonly produced hormone in excess in adrenal cancer, along with testosterone is the other one that we commonly see. But many of these symptoms are very similar to much more common problems like high blood pressure and diabetes. And adrenal cancer is not the first thing that a primary care physician is going to think about because it's so rare. Hypertension, diabetes are extremely common. So sorting out why somebody has worsening hypertension and why somebody has worsening diabetes or weight gain can be a prolonged process. And that also delays diagnosis of adrenal cancer.
Yeah, and as you were saying that, I'm thinking the vast majority of primary care physicians have never had someone with adrenal cancer. They're just not familiar with it.
Right, so that's exactly correct. Most physicians will not ever see a case of adrenal cancer. So that does lead to some difficulties for patients in terms of finding physicians who really are experts in taking care of this disease. So this is why it's so important that we have centers of excellence around the country and access for patients to providers who really understand this disease, because it is a difficult disease and difficult cancer to treat and manage.
And so does this mean that by the time a patient gets to you, to your multidisciplinary adrenal clinic, they may be fairly far advanced in their cancer because it's taken so long to get diagnosed and to get to you?
So we do see that in some cases, but the good news is that over the last 20 years or so, there has been increased recognition of adrenal cancer, along with the fact that we're doing so many CT scans for other reasons that we're picking these up much sooner than we used to. And so we're seeing patients at earlier stages in their cancer, at stage 1, 2, or 3, rather than where we were seeing most patients when they presented with stage 4 disease. So the outcomes from adrenal cancer have improved over the years because of earlier detection, but we do still see a fair number of patients who are found late in the disease process, again, because it's hard to pick this up. And a lot of times when we see patients who present and we go back through their histories and their stories of kind of how they started to develop some of these signs and symptoms, we said, yeah, the signs and symptoms were there, but we can't blame the primary care physicians or the internal medicine doctors for delaying the diagnosis, because again, hypertension, diabetes, and those common signs are so frequent that we don't expect that they would jump right to adrenal cancer.
And hypertension and diabetes would not be something you'd get a CT scan for.
You're correct about that.
So that delays it a little further until finally they say, it's not this, it's not that. Let's just take a CT scan to see what's going on. And that's when they hopefully will detect it.
Yeah, in a lot of these cases, patients see their primary care physicians, and if hypertension becomes difficult to treat, then they may send patients on to um, a specialist or someone who specializes in difficult to treat hypertension. That can be a cardiologist, that can be a nephrologist or kidney doctor, that can be an endocrinologist. And especially if patients are having diabetes that's more difficult to treat, then usually they're seeing the endocrinologist, and the endocrinologist, being familiar with diabetes and adrenal disorders, may start to think about an adrenal issue.
Okay, that was a great overview, and we're going to take a quick break. And when we come back, we're going to talk about treatments. In today's world, misinformation abounds, but at the Ohio State Health and Discovery website, we're addressing today's most relevant health, wellness, science, and research topics, all from the Ohio State experts you can trust. We're tapping into physicians, scientists, and thought leaders across our medical center and health sciences colleges to give you the deeper story behind the headlines and the truth about the topics affecting the health of individuals, society, and the world. Visit health.osu.edu today. We're back with Dr. Barbara Miller, the co-director of the James Multidisciplinary Adrenal Clinic. And Barbara, you gave us a great overview of what adrenal cancer is, but now let's go to the next step and talk about treatments and then the multidisciplinary clinic that you help lead.
Sure, sounds great, Steve. So everything's done individualized to the patient, as to what stage they present at, and what hormones they may be producing. But the mainstay of treatment for adrenal cancer is surgery. And we have to determine, based on the imaging studies that we have, one, are we dealing with just a single tumor in the adrenal gland? Has that tumor spread to other nearby organs, which most commonly that would be the kidney? On the right side, sometimes the adrenal cancers can invade into the liver that overlies them. On the left side, it can involve the spleen or the pancreas that overlies the adrenal gland. And then we have to look and see, based on CT scans, if we think we're dealing with something that is an adrenal cancer. Usually we'll get a chest CT scan to look and see if there's evidence of metastatic disease elsewhere. If patients present with metastatic disease, or what we call stage 4 disease, then in most cases we'll recommend that the patients pursue chemotherapy first. And that doesn't mean that surgery is ruled out for down the road. But what we want to do is we want to understand, one, will the tumor respond to chemotherapy? Two, what is the tempo of disease, and how quickly are these, is this main tumor growing, and is the metastatic disease growing? Because that tells us whether or not resection of the primary tumor is going to be advantageous. If we find that there's no evidence of metastatic disease, then usually we'll perform adrenalectomy with or without resection of additional surrounding organs. And the way that that surgery is done is extremely important. This tumor is very fragile, and can grow through the capsule of the tumor, the covering of the tumor, into surrounding organs. And what we don't want to do is we don't want to rub against this tumor. We don't want to spread those cells elsewhere in the abdomen, because that tumor has a very high likelihood of coming back in the abdomen, and we don't want to see that. So we've developed over the years some techniques and some recommendations, and actually we're just coming out with the first recommendations specifically for adrenal cancer through the American College of Surgeons, which is a group that I lead for operative standards in cancer surgery. And basically what we say is that we want to resect not just the tumor, but also the surrounding fat and any organs that are invaded by the tumor. And a lot of surgeons don't treat adrenal cancer very frequently, so they're unaware of the tumor biology and the aggressiveness of the disease, and really the fine details of what it takes to get these tumors out in the correct way to minimize any sort of recurrence in the abdomen. That best approach is usually an open approach. There's been a debate over the last 10 years about doing minimally invasive surgery for these versus traditional open surgery that requires a larger incision. But it's agreed upon by those of us who are experts around the country. In this group involved over 20 surgical oncologists, endocrinologists, endocrine surgeons, pathologists, and urologists. And so really we came together with a consensus and still feel that an open approach is the best from a cancer management standpoint. So many patients like the minimally invasive surgery, but for this it's not optimal. So once surgery is done, patients recover, and then we take a look at the pathology and we have to determine if other treatment is warranted. And that's based on how quickly the tumor is dividing and multiplying, based on what we call tumor grade, whether or not the tumor is spread through small blood vessels or through the lymphatic system to lymph nodes. Those are things that would indicate that potentially we would recommend starting an additional treatment. And many patients will search the internet and they'll come upon a medication or drug called Mitotine. Mitotine is actually a derivative of the insecticide DDT, and it is the only approved medication to treat adrenal cancer, which sounds really, I guess, interesting or archaic maybe, that this goes back to the 1960s and 70s when that was discovered, but that remains the only drug specific to treat adrenal cancer. So in patients who are at high risk based on some of those pathology features that we learn after surgery, sometimes we'll start those patients on Mitotine about 6 or 8 weeks after surgery.
So is that an actual chemotherapy drug or is it something different?
Yeah, it's not really chemotherapy. It's more just a specific medication that targets the adrenal glands. So it does two things. One, it actually impedes the production of cortisol. Not all patients with adrenal cancer produce excess cortisol, but that's one of the things it does. And then the other thing that it does is that it's called an adrenolitic agent. Basically, it kills off adrenal cells, and so that's what we like about it. But at the same time, because it is not only impeding the production of cortisol and killing off hopefully adrenal cancer cells that may remain, we also have to actually give patients steroids and replace their steroids because of the side effects of that medication. So there is chemotherapy that we use in some patients that is generally given to patients who have evidence of metastatic disease or disease that has recurred either in the abdomen or elsewhere. And there are a couple regimens that are most common. One we start with called EDP, which is etoposide, doxorubicin, and cisplatin. That's a 3-drug therapy. And then there's another regimen as well that is a second line. However, that one is not tolerated as well, and we've moved to treating patients many times with immunotherapy agents.
Okay, so you are. I want to go back to the surgery itself. And I had a couple questions. Are you generally removing the entire adrenal gland or just part of it that has the cancer cells in it? And how often do you have to remove both of them? And then how do you replace those functions?
Right. So when we talk about adrenal cancer surgery, what we're doing is we're removing the entire gland. The tumor grows from within the gland, so it doesn't sit on top of it or off the side of it. It actually grows from within it, and so it's very important that we remove the entire tumor, that we don't leave any portions of tumor behind. And so, like I was saying before, there is a surrounding fat pad that we also want to take and remove at the same time. And so any little tumor cells that may be invading from the tumor into that surrounding fat, hopefully we're getting around all of that disease rather than cutting through it. We want to avoid cutting through any sort of tumor cells.
And And you said that if you have one adrenal gland, a person can function, but what if you have to remove both of them?
If we have to remove both of them, then we know up front that we need to give replacement steroids, and that's usually something called hydrocortisone. There are a number of different steroids out there, but hydrocortisone is the generic drug, and that is what's commonly replaced. That's usually taken twice a day. And then we also use a medication called fludrocortisone that replaces the function of aldosterone so that the sodium and potassium are regulated appropriately. In patients who are producing excess cortisol at the time of surgery, that is something that those patients, even if we don't remove the other adrenal gland, assuming that's normal, those patients actually need to be placed on hydrocortisone as well many times, because when you're producing excess cortisol in one gland, the production of cortisol from the other gland shuts down. It doesn't need to work. And so temporarily we have to replace steroids until the function of that other gland returns.
So you and Dr. Kirshner lead the James Multidisciplinary Adrenal Clinic. I'm guessing, based on the few number of cases diagnosed every year, that you're one of the very, very few, and that your expertise is such that you gather people from Ohio and well beyond. So when someone comes to the multidisciplinary clinic, what happens? What do they find there?
Right, so we are one of few cancer centers and multidisciplinary teams around the country that specialize specifically in treating patients with adrenal cancer. Again, it's a very rare disease, and so finding clinicians and other team members who have expertise in adrenal cancer can be difficult. And so when we started this multidisciplinary comprehensive adrenal program, we were very selective about recruiting others to be part of that team. And so our team now consists of over 30 members from different specialties, as well as support services. And that includes endocrinologists, endocrine surgeons, surgical oncologists, radiologists, pathologists. We have a licensed genetic counselor because a certain percentage of these tumors will be driven by a genetic mutation. And so it's important that all patients with adrenal cancer be evaluated for evidence of their tumor being driven by a genetic mutation. We also work closely with radiation oncologists and our survivorship clinic here at the James is an important part of our team, and social workers and other support personnel.
So you really need a large comprehensive cancer center and hospital in order to have all these experts in place.
Yeah, it really is important to have a large multidisciplinary team so that we can provide the necessary care to each patient in a very individualized fashion. So we actually have a multidisciplinary tumor board that runs every week, where many of us from within the team will get together and we will discuss cases and patients and come up with various plans for each person. And everyone coming from a different specialty has a slightly different viewpoint, and so we try to come up with the best plan for each patient depending on their particular disease process and where they are at in that disease course.
That's the no routine cancer philosophy, right?
Exactly, yeah.
Now, because adrenal cancer is so rare, only a couple hundred cases a year, I'm guessing perhaps it doesn't get the exposure, which in turn leads to research dollars that more common cancers get. How do you advocate for that? What is the situation in terms of research and finding improved treatments?
You're exactly right. Research for adrenal cancer is extremely underfunded, as is the case for probably all rare diseases. And so when we're advocating for research funding for adrenal cancer, we're also advocating for research funding for rare diseases in general. Adrenal cancer would be considered from a number standpoint an ultra rare cancer. And so the government obviously is where we get much of our research funding. And because they're looking at cancers that affect more of the population, we don't receive a lot of funding. So it's very important for us to think creatively and reach out and seek funding from unique donors and sponsors. We work closely with patient advocacy groups. ACC Warriors has been a big supporter of ours. The National Adrenal Disease Foundation is also an important group that we work with. Other alliances like the PHEOPARA Alliance and the VHL Alliance, those are all partners of ours because not only is adrenal cancer rare, but other benign and other malignant adrenal tumors are also very rare. So we are constantly searching for funding. Pelotonia is a big supporter, obviously, of the James, and so they are also key to our program's success to be able to continue researching this very rare disease.
It seems to me, I guess in theory, I understand why more dollars are going toward lung cancer and colorectal cancer because there's, thousands more cases, but 200 people is still 200 people. But also, it also seems to me that some of the discoveries and research that you and other scientists make for adrenal cancer can have crossover effects to other cancers. So that nothing is done in a silo, and research in any type of cancer just increases the knowledge that helps with all types of cancer research.
Yeah, you're exactly right. That's a great point to make. And that's also why it's so important to have a large multidisciplinary team because there is a lot of crossover between specialties, not only for patient care, but in the research world too. I can say that we have an immunotherapy institute here at the James, and they're doing some amazing research, and that touches many different cancers. We have actually found that steroid production can inhibit the response to immunotherapy. And when you think about the adrenals, well, they produce steroids. And we found that patients who actually produce cortisol from their adrenal cancers do not respond to immunotherapy nearly as well. But then I also see patients who have lung cancer and other cancers that tend to go to the adrenal glands. And the metastatic disease that's in the adrenal glands sometimes will continue to grow when patients are treated with immunotherapy, when all of the other tumor in the body seems to be able to be treated with immunotherapy, or that we see response in tumor outside of the adrenal glands. So it's really kind of fascinating, but yeah, there's absolutely crossover, and it's extremely important that all of us at the James and around the country and around the world work together. And so we actually have an Adrenal Alliance. It's called A5, the American Australian Asian Adrenal Alliance, and that is a network of clinicians and researchers who have expertise and interest in taking care of patients with adrenal disorders, adrenal cancer, and performing research on various adrenal disorders. And so we're able to share experiences, look at outcomes, and then also share tissue samples within the Alliance members so that we can drive care forward and progress, and really have learned a lot over the last probably 15 or 20 years. So there is a lot of promise in the future, and we are making strides in caring for patients with adrenal cancer.
Well, thank you for sharing a lot of great information, and we appreciate it.
Thanks very much for having me.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Soloff Research Institute. For more information, check out our website, cancer.osu.edu.